United Blair Hospital. So I'm going to talk about sonographic evaluation of the neck, where we're going to look more than just the thyroid. So we're going to touch on imaging of the thyroid, imaging of the parathyroid, and congenital cystic lesions that are seen in the neck. We're also going to look at a few solid masses of the neck and neck masses that are found in children. We're also going to look at sonographic evaluation of cervical lymph nodes and imaging post-thyroidectomy, ultrasound imaging post-thyroidectomy. So for our normal thyroid gland, this is just a clinical picture where we have our both thyroid lobes, including the isthmus. Posterior to it, we have the trachea and the esophagus. On both lateral sides, we have our great neck vessels, that is the internal jugular vein in the carotid artery. Then we have the strap muscles anteriorly, which is the stenohyoid muscle, sternothyroid muscle, and the omohyoid. Then on the lateral side, we have the sternocleidomastoid muscle. So there's an ultrasound picture, which is showing all the structures that are showing up there. So this is our trachea, our thyroid lobes, our isthmus, and the strap muscles in front. Then we've got our sternocleidomastoid muscle on both lateral sides and our great neck vessels. So the normal thyroid has got a homogeneous ecotexture and normal volume. In females, it is less than 18 mils, and in males, it's less than 22 mils. And on color Doppler, we should readily see flow scattered throughout the gland as seen on the image below, but it should not dominate the gland or have abundant aliasing. You will see as we go through what causes which conditions have got abundant aliasing. So just to mention a few variants which may be mistaken for thyroid nodules. There is what is called a pyramidal lobe, which is an embryonic remnant of the thyroglossal duct, which is labeled here. So we've got our thyroid gland, this one, this is our pyramidal middle lobe. So on ultrasound, we actually detect it about 15 to 20%, but clinically it is not detected. So often, it is often missed surgically if it's not recorded on ultrasound when patients undergo total thyroidectomy. So it is important to note down when you do an ultrasound evaluation of the neck and you see a pyramidal lobe, because this is also thyroid tissue. It's also affected by all other conditions that affect the thyroid gland. So in case someone has got undergoes total thyroidectomy for papillary thyroid carcinoma and this lobe is missed, it can recur. The carcinoma can recur and continue to grow in the pyramidal lobe. And we can see it on ultrasound as an extension of the normal thyroid lobe. This is our longitudinal section. We've got our normal thyroid lobe, and this, where these arrows are, is the pyramidal lobe. So the echogenicity is the same as the thyroid lobe. As we say, this is the thyroid tissue. This is another image showing the pyramidal lobe in the transverse view. So this is our normal thyroid lobe. This is our extension of the thyroid tissue, which is the pyramidal lobe. In the longitudinal sagittal view, this is our pyramidal lobe. Another one is the tubercle of Zuccantel, which is more on the lateral side. So as seen on this image, this is our normal thyroid lobe. So this is our tubercle. So it is variable in size and it is adjacent to the laryngeal nerve and it is superior to the parathyroid, which are seen this side. And it originates from the pharyngeal pouch. So it is just small tissue of thyroid, which is attached posterior to the thyroid gland. So it is mostly mistaken for parathyroid, since we said it's posterior to the thyroid gland. It can also be mistaken for a lymph node, or it can be mistaken for a thyroid nodule. But to distinguish it from the thyroid nodule doesn't have a white outline. You will see on the coming images, which is the echogenic fibrous band. So that's how you distinguish it from the thyroid nodule as seen in these images. So this is our tubercle, this one. So this is the white line that I was talking about that will make you differentiate it from a thyroid nodule. This fibrous band, also seen here in the transverse view, and also seen on the other image. So moving on to the perfusion of the thyroid gland, it can be increased in several occasions, in several clinical settings. For example, in an increased cardiac output, for example, in a stress patient, in also pregnant patients, it's increased. And during an active autoimmune inflammation, for example, in Graves' disease or Hashimoto's thyroiditis, and in untreated primary hypothyroidism because of continuous TSH stimulation. So in Graves' disease, it is actually markedly increased that it gives what is called the thyroid inferno. You will see images later on. So Doppler imaging is very crucial in differentiating thyrotoxicosis. So we said it is increased in Graves' disease and hyperfunctioning nodules, and it is decreased in settings of thyroid tissue, in the breakdown of thyroid tissue, as in case of postpartum thyroiditis and subacute thyroiditis or aminodiarin-induced thyrotoxis. So the most common pathologies which are found in thyroid include thyroiditis, and these are types of thyroiditis, and we also have got thyroid malignance. And in thyroid malignance, the most common one is the papillary carcinoma, which constitute about 78% of the carcinomas of the thyroid. Then we also have got follicular lesion carcinoma, which constitutes about 17%. We also have medullary carcinoma, which constitutes 4%, and anaplastic carcinoma, which is about 1%, then thyroid lymphoma, which is very rare. And we can also get metastasis to the thyroid lobe, but it is very rare. So on the thyroid nodule, we need to distinguish between benign and malignant. The most common is the multinodular goiter. So to distinguish between malignant and benign nodules, we use what is called ThyRISE, which is thyroid imaging reporting and data system. So it is important to make a diagnosis of it is important to note that we can not make a diagnosis of malignance without biopsy. Biopsy gives us a definitive diagnosis. And most of thyroid nodules are benign. So there are different, these thyroid classifications are different. I've just chosen two, which are a bit simpler. This is the American College of Radiology thyroid classification. So it considers 5 features of our lesion, which is composition, echogenicity, shape, margin, and echogenic foci. So we score our lesion based on this table, where our cystic or almost cystic lesions get 0 points, mixed cystic get 1 point, and so forth. Then we also move on to echogenicity and across all board. So what we will do after that, we have to choose one on each category. Then we add our points to get a total. The total is the one that will help us classify our nodule. So if our total is 0, then it is definitely benign. It means there was no abnormality seen. So we are on thyroid classification 1, and there's no need for fine needle aspiration because there's no abnormality. Then if we get 2 points, we have a lesion, but it is not suspicious. So we don't need fine needle aspiration on that lesion. If we get 3 points, we are now mildly suspicious. So according to the American College of Radiology, if it's greater than 2.5 centimeters, we need to do fine needle aspiration. If it's greater than or less than 1.5, then we can follow up that lesion. If it's it has 4 to 6 points, it's now moderately suspicious. So fine needle aspiration is now done on a lesion that is greater than or equal to 1.5. And we follow on lesions that are less than 1 centimeters. And if we have 7 points or more, it is highly suspicious. So we do fine needle aspiration on 1 centimeter, and we follow up on lesions which are less than or equal to 0.5 centimeters. Then we also have got Korean thyroids. So on this one, it is categorized as on the purely cystic lesions or the purely cystic lesions, and those which are partially cystic with cometal artifact and spongiform lesions, they are all benign and they are classified under thyroids too. Then on the partially cystic lesions or those who are which are hyso or hyperechoic, if there are any suspicious, if there are no suspicious features, ultrasound features, then we classify it as low suspicion. But if there are suspicious features, we classify it as intermediate suspicion. On solid hypoechoic lesions, we also look at suspicious features. If there are none, then we classify it under 4. If there are any suspicious features, then that's high suspicion. We classify it under 5. So some of the suspicious features include microcalcification, non-parallel orientation, that is taller than wider, spiculated or microlobulated margins. Okay. So on ultrasound evaluation of our nodules, we've got characteristic features for benign nodules. We've got characteristic features for malignant nodules, but we also have got some features which are borderline. They're indeterminate. They can be found on both benign nodules and on malignant nodules. So on the benign features, that's we have our ovoid shape, isoechogenicity or mildly hypoechoic when we have a smooth margin, and all our spongiform lesions or cystic lesions. And if we just find an isolated artifact or cometal artifact in cases of colloid cyst, and if our vascularity is peripheral, then those benign features, those features favors benign. On the malignant features, we have got marked hypoechogenicity. So if we are saying marked hypoechogenicity, we are comparing the lesion to the strap muscles, which are anterior to the thyroid lobe. So if they are more darker than the strap muscles, that's marked hypoechogenicity. So that's a malignant feature. If they are subcapsular, and if they have an irregular margin, either spiculated or microlobulated, if they've got microcalcifications, in the non-parallel orientation that is taller than wider, and increased intranodular vascularity. And if we also see associated lymphadenopathy, those features favor the malignant. But the intermediate ones include hypoechogenicity. Is not definitive, it's indeterminate. We can't classify it either on benign or malignant. If they're inhomogeneous, and if we see centrally predominant vascularity, or we see microcalcifications like axial calcifications or intranodular calcifications, which are bigger. So when we have got the borderline features, we need to consider other features and not just choose those ones found in the borderline features to classify our nodule. So besides the nodules of the thyroid, we also have got autoimmune diseases. So they've got a typical ultrasound appearance, which include enlargement of the lobe, the thyroid lobe. It also includes altered parenchymal echo texture and or echogenicity, both. It can be both or just one. And we also get increased vascularization, and we may get associated lymphadenopathy. So autoimmune pattern is actually more specific for diagnosis of autoimmune thyroid disease than detecting antibiotics on lab evaluation. So it is actually, it has been noted that we can actually pick autoimmune disease early on ultrasound, considering these ultrasound patterns than evaluation with lab findings. And we might get other cases where we've got our enlarged thyroid, but it still has normal echogenicity and echo texture. So it can be found in different clinical settings. It can be a normal variant, considering the height of the patient, considering the BMI, considering the gender. As noted earlier, there's actually difference in the upper limit size of the thyroid lobe in females and males. So it could be due to gender. It could also be due to race. It could be due to age. In some clinical settings, it can be due to mild iodine deficiency, and other medical conditions such as pregnancy and chronic renal disease can also result in the enlargement of the thyroid gland. or subclinical autoimmune thyroid disease. So if we get an enlarged thyroid with normal echogenicity and echotexture, we need to correlate it with serum TSH in order to rule out if it's just normal variant or it can be associated with other clinical conditions. On the autoimmune disease, I'm going to start with the Hashimoto's thyroiditis, which is the most common autoimmune disease of the thyroid gland, and it is most common cause of hypothyroidism in areas where there's iodine, where there's sufficient iodine. So our gland on ultrasound, it is diffusely enlarged and it has got a heterogeneous echotexture. This results in fibrosis of the gland. That gives us the heterogeneous echotexture. So we'll get the echogenic fibrous strands on the USS image. It can also give us what is called the giraffe pattern, which is a pseudonodular pattern. We've got our small hypoechoic micronodules, which are approximately 1 to 6 millimeters, and they are surrounded by echogenic septations. That gives it the giraffe pattern. And on color Doppler, it is usually normal, or it can have a decreased flow. And we also get prominent cervical lymph nodes, which are mostly found on level 4. We are going to talk level 6. We're going to talk about levels of cervical lymph nodes towards the end of the presentation. But these lymph nodes will have normal morphological features because they are reactive cervical lymph nodes. But patients with Hashimoto thyroiditis, they've got an increased risk of PTC. So if we see any nodule in someone with thyroid, Hashimoto thyroiditis, it is recommended to consider that lesion for biopsy to rule out papillary thyroid carcinoma. And it is also associated with, if you see someone who's got high Hashimoto thyroiditis, most of the family members also have got the same disease. So these are just some ultrasound images showing Hashimoto thyroiditis. Our gland is diffusely enlarged and it has got a heterogeneous echotexture. So these are the fibrous echogenic strands from fibrosis of from Hashimoto's disease. This is also another image, heterogeneous echotexture, and this is an image showing color Doppler. So color Doppler actually depends on the stage of the disease. So in some cases, we might actually get increased color flow, but in most cases, it is normal or decreased flow. Then we can move on to subacute perioditis. This is usually occurs after some respiratory infection, which can be viral or bacterial. So on the initial phase, clinically, it is accompanied with hyperthyroidism. Then we can get migrating neck pain, we can get increased temperature and other constitutional symptoms like malaria, arthralgia, and fatigue. On lab evaluation, we get elevation of the serum acute phase proteins, that is C-reactive protein, and the blood sedimentation rate is also increased. Then on ultrasound, we get our irregularly shaped hypoechoic areas as seen in this image, and hypervascularization is not present compared to other forms of thyroiditis as seen in the other image as well. And we move on to Graves' disease, which is also another autoimmune disease, thyroiditis. So it is also the most common cause of thyrotoxicosis. And on serology, that is lab, our TSH is suppressed. Then we get elevated T4 and T3, and we also detect the TSH receptor antibodies. So they'll be positive on serology. On ultrasound, our gland is enlarged and it can be hyperechoic. It has a heterogeneous echotexture. Usually we don't get nodularity in uncomplicated cases compared to Hashimoto thyroiditis, and we don't get fibrosis, so we don't get the fibrous strands as compared to Hashimoto thyroiditis. And on color Doppler, it is hypervascular. It is markedly hypervascular that it gives us what is called thyroid inferno on color Doppler. Then we have got prominent extrathyroid vessels, which have got very high velocity flow, that it can have a peak systolic velocity of 40 centimeters or higher. So it actually has 96% sensitivity and 95% specificity for diagnosing Graves' disease, which is actually better compared to lab evaluation. So these are images also showing our diffusely enlarged gland on longitudinal section and on transverse section. Both thyroid glands are enlarged, including the isthmus. Then this is the thyroid inferno on color Doppler. We also get acute suppurative thyroiditis, and this one develops secondary to systemic diseases, immunodeficiency conditions, or traumatic events such as fine needle aspiration. On lab evaluation, we get elevated white blood cell count and ESR and CRP levels. They can also be seen. Then on ultrasound, our gland will be diffusely enlarged and it is somewhat irregular, and it has decreased echogenicity. This is the side which has been affected. This other side is normal, and our isthmus is normal. And it has got a heterogeneous lesion, which is composed of septated cystic component, as seen in this image. This is just another image also showing a case of acute suppurative thyroiditis. So we've got different diagnoses in patients who present with neck lump besides the thyroid nodules. So we can get fetro at the base of the neck. It can be due to lymphadenopathy. It can be due to brachial cleft cyst. It can be due to thyroid glossal duct cyst. It can be due to parathyroid gland mass. It can be due to a sebaceous cyst, and it can be due to a lipoma. So I'm going to talk about lymphadenopathy, brachial cleft cyst, thyroid glossal duct cyst, parathyroid gland mass. Lipomas, the ultrasound appearances are the same everywhere, so I didn't see need to talk about it. So on parathyroid, when the parathyroid is normal, we don't see it on ultrasound. We can only see it when it's now abnormal. So when it's now abnormal, the most common pathology is parathyroid adenoma, which is seen as an enlarged parathyroid gland. It has got a characteristic ultrasound appearances that is oval to rounded in shape, and they are uniformly hypoechoic, as seen in the images below. It may be very difficult to distinguish from the thyroid lobe, especially in the longitudinal view, as seen in this image. You might actually mistake it for a thyroid nodule, but at least in the transverse view, you can see it separately from the thyroid gland, which is this normal structure. It is posterior to the thyroid gland. So you need to be very careful to assess your thyroid lobe in both transverse and longitudinal view to determine whether the lesion that you are seeing is within the thyroid lobe or is outside the thyroid lobe. Then we move on to brachial cleft cyst. It is usually seen in patients between the age of 10 to 40, and it presents as a painless lump, and it has smooth margins. It is located along the anterior border of the sternocleidomastoid muscle. So these are just some images showing our brachial cleft cyst. So we need to differentiate it from metastatic cystic nodes. So the most important thing that helps us differentiate it is the location. The location of the brachial cleft cyst is at level 2. As I mentioned earlier, you will see the levels at the end of towards the end of the presentation. Then if it's a metastatic lymph node from papillary cancer, it is usual. If it's solitary, most of the time they are multiple. But if it's solitary, it is usually located at level 3 or at level 4. Then we might also need to check for primary tumor if we are suspecting that it is a metastatic cystic node. We need to check the thyroid for the primary tumor. Or if we want definitive diagnosis, we can do fine needle aspiration. We also need to differentiate it from a metastatic squamous cell carcinoma. This presents with internal necrosis, and it has an irregular wall. As we mentioned earlier, our brachial cleft cyst has a smooth wall outline. And the squamous cell carcinoma metastasis also have got septations. Another cystic lesion which is seen in the neck is the thyroglossal duct cyst, and it is usually seen before the age of 30. It also presents as a painless, smoothly margined cyst, and it is midline. Our brachial cyst was lateral. It is midline or paramidline, and it is usually seen 2/3 below the hyoid bone. So our hyoid bone is somewhere here. So this is our thyroglossal duct cyst. So these are just some ultrasound images showing our cyst. So it can actually grow huge and become infected as seen in this image. This is our thyroglossal cyst, which has grown huge and has become infected, and therefore we are seeing this internal. Therefore, we are seeing these internal echoes within our cyst. We can also get solid masses, solid neck masses, and one that I chose to talk about is the carotid board tumor. So the patient presents with a painless mass in the upper lateral cervical neck. Upper lateral neck. It can be pulsatile, and it is usually located between the internal carotid artery and the external carotid artery, as seen in this image. So this is our internal carotid artery. This is our external carotid artery branching from the common carotid artery. So this is our carotid board tumor. So it has increased vascularity as seen on the image, and it can also be locally invasive, or it can metastasize to other areas. And in most, it can be bilateral in 10 to 30% of the cases. So if you see one on the other side, it is advisable to check the other side as well to rule out bilateral carotid board tumors. Then we can also get what is called Zenka diverticula, and it can mimic a thyroid nodule. This is our diverticula. Usually, barium swallow is the imaging modality of choice, which is used to diagnose this, but we can also see it on ultrasound as we are doing an evaluation of the neck. So I thought it is important to talk about it. So it is usually seen as an isoechoic or hypoechoic mass with internal peripheral echogenic foci mimicking calcifications, these ones seen in the image. So this can mimic calcification. So it has got this hypoechoic zone around the mass or the lesion. So we also need to look for connection with the esophagus, and it usually changes in shape and size. It can actually change during the scan or after, or even after you biopsy the lesion. The lesion can change in both shape and size. Most of the time, it's usually left-sided, but it can also be found on the right side. So this is just a barium swallow image showing our diverticulum, this one, which is been filled in with barium. So also a special mention in children, we also have got various neck masses. So on the cystic ones, depending on location, we've got on the midline, on the upper part, we get what is called a granular cyst, which is just a rare benign acquired cystic lesion that usually occurs the floor of the mouth, a sublingual or minor salivary gland retention cyst. Then we also have got the thyroglossal cyst, which is the same as we talked about earlier on. Then on the lower part, we get the dermoid cyst. On the lateral side, we can also get the brachial cyst. We've talked about it earlier. We can also get lymphangiomas. We can also get vascular malformations. Then on the solid lesions, we can have the lymph nodes, which can be either reactive lymph nodes, which can be lymphadenitis or lymphomas. Then we've got other solid lesions, which we have uncommon solid lesions like thyroid lesions. Then we also have got fibromatosis coli. This is common in neonates, and it is literature believes that it is due to birth trauma. So this is just proliferation of the fibrous tissue of the sternocleidomastoid cleidomastoid muscle. So due to hyperplasia, the muscle becomes thickened, so it becomes short and bulky, and it gets the fusiform shape instead of the normal longitudinal shape. Then we've got pilomax trichoma. Then we also have got ectopic thymus. Then on the very rare ones, we can get the teratomas, the rhabdomyosarcomas, the neurofibromas, and the neuroblastomas. So these are just locations of the masses that I was talking about. The ranula, which is below the mandible. On the midline, we get the thyroglossal duct cyst, and below we get the dermoid cyst. Then on the sternocleidomastoid muscle, which is this one, that's where we get our fibromatosis coli. On the lateral side, we can also get the brachial cyst. Then we can also get our lymphangiomas on the lateral neck. So these are just images showing the masses that we're talking about. This is our ranula, submandibular gland. Then we have our ranula and an accompanied MRI image. This is our dermoid cyst. This one measured here. This is the pseudotumor of the sternocleidomastoid muscle, which is the fibromatosis coli. This is our neurofibroma, which is this one, and this is our this one. What is the, sorry, the pilomax trichoma. Then we can move on to cervical lymph nodes. So on cervical lymph nodes, we are going to talk about the anatomical landmarks for distribution of the nodes. We are also going to talk about the criteria for normal and abnormal nodes using ultrasound. We are also going to talk about the technique for USS-guided fine needle aspiration. So we use a high-frequency linear probe for assessing our lymph nodes. And we have to scan from level 2 to 5 with particular attention to nodes along the jugular vein, which is called the jugular chain. And we have to use color Doppler on any potentially abnormal lymph node. So our anatomical levels, they correspond to our anatomical spaces. So we've got level 1 up to 7, but some can just use level 1 up to level 6. So our level 1 is further divided into level 1A and level 1B, which is the submental is the level 1A, then the submandibular is the level 1B, is noted on the image. Then we've got our level 2, which is the upper jugular. It is also divided into 2A and 2B, where 2A is the anterior inferior, then the 2B is the posterior inferior superior. Then we move on to level 3, which is the mid-jugular, this part. Then we move on to level 4, which is the lower jugular. Then the level 5, which is on the posterior triangle, which is also further divided into 4A and 4B, which is just the superior and the inferior. Then we go to our level 6, which is the anterior compartment. Some sources say the central compartment is just one and the same thing. Then the level 7 is the upper mediastinum, which is down there below the clavicle. So on characterization of our lymph nodes to determine whether they are normal or abnormal, we use the size, we use the morphology, we use the echogenicity, and we also use color Doppler. So on size, the upper cervical lymph nodes are usually larger. So for the normal, and if we are saying normal size, we are considering the short axis of the lymph node. So for the upper cervical lymph nodes, since we say they are usually larger, so we take the upper limit is 8 millimeters for lymph nodes at level 2. But for all other levels, 5 millimeters for our short axis is the upper limit for normal size. Then for morphology, they have to be elongated and oval. They should not be round. And on the echogenicity, it should be hypoechoic with, or sometimes we cannot see the echogenic hilum. So if we see the echogenic hilum, it is highly assuring of a benign node. For color Doppler, we should see central flow, or sometimes we cannot pick flow. So as I mentioned earlier, when we're talking about the size of the lymph node, it is only the short axis measurement which is relevant. So we don't assess the lymph node size using the longitudinal measurement. We only use the short axis measurement. So does that mean that all the elongated lymph nodes are normal? No, it doesn't. We now need to consider the echogenicity, and we also need to consider the color flow, which will determine whether the lymph node is normal or abnormal. So for reactive lymph nodes, they are usually enlarged and they may demonstrate increased flow, since we are saying these are reactive, and they always have got a central pattern. And echogenicity is supposed to be always normal for reactive lymph nodes. Then we move on to our abnormal lymph nodes. We said our short axis is now enlarged. That gives it a rounded shape instead of the oval or elongated shape. And it might have irregular borders, for example, in cases of TB adenitis or tumor infiltration. And then we have the loss of our echogenic healer. On the morphology, it can have internal cystic change, it can have calcifications, or it can have increased echogenicity. And on color Doppler, the color flow is increased and it is peripheral, and we can also see some disorganized flow pattern. So abnormal echogenicity is often a key point. If we see cystic areas, if we see calcifications, and if we see increased echogenicity, then that definitely means that lymph node is not normal. And mostly in PTC, that is papillary thyroid carcinoma, the echogenicity of the metastatic lymph node is often different from the primary tumor. So most of the papillary carcinomas are hypoechoic. So you will note that their metastatic lymph nodes are hyperechoic in most of the cases. Then we move on to ultrasound-guided biopsy of our lymph nodes. This also applies to even thyroid nodules. The same technique applies. So we've got two techniques, and you will notice that surgeons, different surgeons have got different preferences. But as a radiographer or as a sonographer, it is important that we master both, because we will meet surgeons who prefer different methods. So it's for our own good to just master both sides, both techniques. So for the parallel technique, we place our needle at the short edge of the probe, as seen in this picture, and it should be placed right next to the probe. So the entire shaft of the needle actually penetrates through the patient to reach the nodule. So the disadvantage of this technique is the more component of the needle is inserted into the patient for us to access the node. Then we can also use the parallel technique, perpendicular technique, where the needle is placed in the middle and it points directly above the nodule, and it's directed straight into the nodule. So on ultrasound, we only see the tip of the nodule instead of the entire shaft of the nodule. But however, this requires someone who has more skill, and you need to understand the spatial relationship between your nodule and your needle so that you can direct the needle into the lesion. So these are just some ultrasound images showing the parallel technique, so we can actually see the entire shaft of the needle as it penetrates our nodule. This is the same technique. This is just a pictorial diagram. And in ultrasound image, we can see the entire shaft of the needle. On parallel technique, because we are directly on top of the nodule, on ultrasound, we are now going to see only the tip of the needle in the nodule. So this is our nodule. This is our tip of the needle. So it is advisable that when we are biopsying our nodules, we need to direct our needle away from the cystic areas, because most of the time the cystic areas are due to necrosis. So they won't give us any positive diagnosis on fine needle aspiration cytology. So we need to direct our needle away from the cystic areas we can actually just drain the cystic fluid and proceed with our fine needle aspiration. And we also need to direct it away from visible blood vessels so that we avoid hemorrhage and complications during the procedure. It is also important for us to talk about ultrasound assessment of the neck post-thyroidectomy. So we always need to scan the thyroid bed and we need to scan the trachea for local recurrence. And unfortunately, there are no distinction ultrasound features of these recurrence nodules. But if we get any nodule that is greater than 5 millimeters, it is advisable to biopsy that nodule to send for fine needle aspiration cytology so that we rule out recurrence. And if we then see color flow on that nodule, then that lesion becomes very suspicious. And most of the nodules are hypoechoic in 70% of the time, and they've got well-defined margins in 100% of the time. And we might also see microcalcifications. And differential diagnosis to consider post-operation, if we see lesions, is what is called the suture granuloma, and we might also get fat necrosis. So we're just going to talk about suture granuloma, which is seen in these images. So these are usually small hypoechoic lesions, and they've got an echogenic foci, which might mimic calcification as seen in these images. These are our echogenic foci. These are echogenic foci in our suture granuloma. So this can actually be mistaken for calcifications. And they are usually paired and more irregular in shape, and they are clustered centrally or paracentrally, and they can be greater than 1 centimeters in diameter. And we are not supposed to see color flow because we're saying this is a suture. So if we turn our color Doppler, we should not see any color flow on that lesion. Thank you. That is all. We can open the floor for questions.
All right, thank you so much for that presentation, Temptation. We are really grateful. At this point, we'll allow for questions, and I think for this session, either Trinus or Atupele will be responsible for allowing participants to make their contributions. Atupele, you can take over.
Ines, I think I'll hand over to you for the questions session, and then I'll take over from you.
Thank you. I think we're going to leave this time to all those who've got questions. I see a hand that's raised there. You can just unmute yourself and ask your question.
Nchete, you can go ahead. Mr. Nchete, you have your hand raised. You can go ahead and ask the question.
There's also Mr. Mayanja raising his hand. I think you can take over. Mr. Mayanja, you can go on. Mr. Mayanja, I see your hand raised. You can ask. Oh, can someone just, can Mr. David, can you please assist? Can you please unmute his mic? I think he's failing to unmute his mic.
Okay, let me do that just now. Whose hand is up?
It's Mr. Julius Mayanja.
Okay, I think they can. Julius, you can unmute yourself.
Hello.
Good evening. You can proceed.
Hello. Can you get me?
Yes, we can hear you. You can ask.